Hey, so hello everyone, and welcome back to another episode of A Doctor's Insight. Today we are going to be talking to Dr. Megan Stross. Megan grew up in Cardiff before moving to Bristol University. After qualifying in 2015, she has undertaken her junior doctor training around various hospitals in England and South Wales. In 2017, she took a year out of training as a simulation teaching fellow, giving her the freedom to teach Birmingham medical students via sim. On returning to Wales in 2020, she started training as a geriatrician. Now an ST5 in care of the elderly, she is working as a clinical teaching fellow for Cardiff University. Now married and living in her own home, she's settled back into living in Cardiff. She enjoys cycling to work and running with her local group, and she's also giving Sarok dancing a try. So thank you, Dr. Strauss, for talking to me today.
Hi, Shanta.
So I want to get started by asking you to tell us a bit more about your specialty.
So about care of the elderly.
Yes.
So I think the first thing to say is that people often think about care of the elderly in terms of age. There's no real cut-off for age in terms of care of the elderly. It's more around frailty. So about how the body may change with time to become less resilient to stresses or to accumulate lots of different comorbidities and difficulties carrying on with day-to-day life. And my task is to try and support people to carry on as independent life as possible, really.
Perfect. So can you go in to describe a typical day or even week in care of the elderly?
So as a specialty, generally you would have a mixture of roles. So you would spend some time on the wards, and that could be an acute front door frailty. So that would be people who just come into A&E, and you would be trying to assess them, give them, I guess, an MOT, for want of a better word, turn them around and get them home as soon as possible. For my frail patients, hospital is often the worst place for them. Or it could be patients who've been in for a few days or even, unfortunately, a few months waiting for social care that you see on the wards, undertake a ward round and try and support those people. You'll spend a significant amount of time speaking not just to the person, but actually sometimes that person can't make decisions for themselves. So you spend a lot of time speaking to relatives and making decisions with the relatives, but also with your team. So one of the things I like about geriatrics is that you're not just there as the doctor making decisions, you make decisions as a team. So physiotherapists, occupational therapists, speech and language therapists, nurses, etc. The other side of that is that then there are lots and lots of subspecialties within geriatrics. So it could be falls, continence, memory problems. So you might do clinics as well through the week for various subspecialties within that. And that would probably be the bulk of your work.
So how does being a CTF fit into that week?
So this year, I'm taking, in some ways, a year out of training, although it does count towards my training. So I'm still doing the clinic side of things, but I'm not on the wards. So in the time that I would otherwise be on the wards, I've got the joy of teaching various medical students and some junior doctors, particularly around the geriatric subspecialty.
And do you miss being on wards, or are you enjoying being a CTF so far?
It's a much more work-life balance role, and I love teaching, and it's really lovely to try and get what's good about the specialty across. I think a lot of people hear about care of the elderly, hear about geriatrics, and think of sort of boring, stuffy wards where not much happens. And it's a privilege to try and sort of highlight the real advantages of geriatrics as a specialty. I think probably after this year, I'll be very happy to go back on the wards again, though, because that's the main job at the end of the day. I hope long term, though, I'll be able to get a balance, so be able to have some teaching time tied into my long-term work schedule.
So I know our main focus of the interview is care of the elderly, but can you briefly just give some advice to junior doctors or medical students who may be thinking of pursuing a clinical teaching fellow role?
First thing would be do it. It's such a good job. It's so fantastic. There are lots of different types out there. So you mentioned in the bio that I did a year as a simulation teaching fellow. So that's where you essentially get to do mock real life practical scenarios with mannequins. All the way, and then this is more sort of tutorial based and bedside teaching based. It's generally such a fantastic work-life balance, so it takes you a year out of the chaos of hospital life. And if you enjoy teaching, it's just such a great opportunity to teach. And generally during these years, you have that time to also do those dreaded things that poor junior doctors have to try and juggle, which is try and bulk up their CV as well to get the points on their applications for getting into what specialty they want to do long term. And so you can get lots and lots of points in that 1 year towards that without trying to do it in your weekends off and your evenings off during a normal job.
Sounds very appealing. So going back to care of the elderly now, can you go through briefly some common presentations that you may see?
So I think the thing with care of the elderly is that whereas with a lot of medical specialties, a patient will come in and say, I have a problem with X. So it might be chest pain or shortness of breath. With geriatrics, the problem tends to be much more vague. So I'm not as mobile as I was, or I'm falling over more, or I'm more confused. And so the problem isn't necessarily directly the confusion. The problem is that there are lots of other things going on that you've got to tease out, either through talking to the person, their family, examining them, or tests to see what is it that's combined together to mean that that person's now presented in a little bit of a heap in a way, and needs sort of support to get back on their feet again.
And what are the outcomes for most patients? I know it varies depending on what they come in with, but generally we hear about care of the elderly patients going on to need social care. How would you describe their outcomes generally?
It completely varies. So you can have, and I don't want to use age, but for example, you can have 90-year-olds who ends up on a care of the elderly ward with quite a nasty pneumonia, who you treat for a couple of days with antibiotics and off they trot back home and carry on driving themselves to the supermarket and carrying on an independent life. You can also have some people who perhaps were just about managing their neighbours and their family members were sort of patching things up at home. And this presentation to hospital is more about them having had that last straw or that crisis point that meant that actually they've realised they can't be supported at home anymore and need some more support. I don't actually know the statistics in terms of who ends up going back to their own home versus sort of sheltered accommodation or a care home of various types. But really the drive is to keep people as independent as possible. So we would work very hard to keep people's independence and not just say, oh, it's easier, let's put them in a care home.
So really age is just a number. It's highly dependent on how they were before they were admitted to hospital.
Definitely, and how much that sort of acute problem has impacted them. So unfortunately, we know that if you've had 4 weeks, or sorry, if you've had 2 weeks of staying in bed, it'll take you 4 weeks to get your muscles back to how they were before. So a patient coming into hospital who has a longer illness has a longer period of time to get back on their feet again and get their independence back again, which is part of the reason you hear things like PJ paralysis bandied about, and part of the reason why we try and get people out of hospital as soon as we can.
Okay. And what is your favourite part about the specialty?
I think for me, it's seeing the person behind the patient. So we get to talk to the person about them as a whole, think about them in their life, and think about them with their family, think about them as a whole picture, and with them make decisions for their quality of life. It's not about or your blood pressure's high, so you've got to take these tablets every single day of your life and you won't feel any better whatsoever after taking them for 30 years. But I promise you, statistically, we know that you'll be less likely to have a heart attack. actually I can say, well, these are the pros and cons of the decision we're making. This is around your quality of life for you as an individual. What's best for you at this stage?
So it's holistic care is what I'm getting.
Yeah,
Yeah.
yeah, definitely.
And if anything, what is your least favorite part?
I think for me at the moment, with the problems with funding in social care, it's that we have patients coming into hospital who have to wait weeks or sometimes months to see a social worker to then start the discharge planning process, to get them either the support that they clearly need at home in terms of a package of care, or get them into a care home. And in that time, I'm seeing my patient get less and less independent, get more and more institutionalized, and get more frail, and need more and more support. And in that time, patients get bed sores, people get pneumonia, hospital acquired, people get other infections, COVID, and you just see in that short period of time they're in hospital that they do decline. And if we were able to get them out of hospital sooner, they could have retained so much more independence.
So that must be very frustrating, seeing a patient coming in, you being able to take care of them, and almost it being out of your hands how quickly they're able to go back into their usual environment. How does that make you feel?
It's devastating. It's absolutely devastating. There's absolutely nothing that we can do. The money is just not there. Everyone is working their hardest. You know, social workers are stretched beyond belief and leaving the specialty in droves because it's just such a difficult task for them now. And everyone is trying their best, and yet still we're in the position where our lovely patients are being let down by the system, and we can't do anything about it, and it's just horrendous.
And has it always been like this, or has the position that the social care workers are in gotten worse? Like, how has the specialty evolved from when you first started until currently?
So it has been getting worse. So it used to be that perhaps you waited a few days to see a social worker, and last time I looked, it was a couple of months. So there's already a delay. We talked about 2 weeks leading to 4 weeks worth of recovery. Where imagine now you're going from 1 week to 2 months. It's huge. So from that point of view, that's had a big impact. It's just that length of time really, and it's a vicious cycle, because if you think about being in the position of somebody like a social worker, who's trying their best, they're getting there after 2 months, and instead of being told thank you very much for coming, it's so fantastic to see you, you're being told, oh, such and such has had 2 pneumonias whilst we've been waiting for you, hurry up, we need to get this person out of here. It's just such a thankless job these days. The relatives, the patient are unhappy. Where have you been? And that's why people are leaving the specialty. So it's just getting worse and worse and worse every year.
It's unfortunate, isn't it?
Mm.
What resource would you recommend to doctors or medical students who are thinking about pursuing geriatrics as a specialty?
I think trying to make sure that you have a placement in geriatrics would be very good, particularly trying to get a varied placement. So not just on the rehab ward, but trying to see a bit of acute front door frailty would be really good. There is the British Geriatric Society. So that is a society around geriatrics. They have courses and forgotten the word. They have journals that come out irregularly as well that you can read through. And they also have a geriatrics for junior session, sort of periodically through the year, so that it's aimed more at junior doctors rather than necessarily consultants looking for subspecialty information. So probably checking out the British Geriatric Society website would be a good place to start.
Perfect. Okay, so we've been talking a lot about what you do currently, and we mentioned in your bio how you arrived at that. But if we can just go back again, can you tell us about how you came to choose the specialty?
Um, I think the first thing to say is if you're a medical student or a junior doctor and you don't know what specialty you want to do, don't worry about it. It develops with time as you gain experience. I did work out very early on that I wasn't a surgeon. And I worked out very early on I was a bit of a jack of all trades, master of none. I wasn't particularly interested in being the top-notch professor who was fantastic at this sub thing. I like to look at the big picture. And so I didn't really consider geriatrics. I thought about A&E or GP, and thinking that GP was the specialty for me. I'd loved it as a medical student. Did my A&E placement, loved the team side of A&E, but hated the lack of continuity of care. Thought, right, GP it is for me, went and did it and hated it. Was very lonely, very vulnerable, thankless job, lots of looking for the needle in the haystack with conditions. And looked back to my geriatric placement and realised I'd loved it. I'd loved working with the team, working with the different members of the MDT, loved thinking about the person as a whole, and really felt that I could make a difference there in terms of thinking about that person, not the patient.
Okay. And what has the training pathway been like?
So to become a geriatrician now is slightly different to when I did it. So essentially you'd be an F1 and F2 on the usual pathway. You'd then go into IMT, being an SHO in medicine. And that's now 3 years. So 2 years is very much an SHO, and then your IMT3, where you're half an SHO, half a registrar. And then you'd apply for geriatrics as a specialty, and you do 4 years as a geriatric registrar before applying to be a consultant.
And often these training pathways can be described as very time intensive. The workload is massive. Can you give us some insight into some of the sacrifices, either personal or professional, to be mindful of when pursuing this specialty?
I think geriatrics as a specialty is perhaps better than many other medical specialties in that, particularly doing it in South Wales, once you become a registrar, you're given South Wales as a deanery instead of the whole of Wales, and you're told your placement's up front for the next 5 years. And so in terms of planning your life, you can do that. However, I qualified in 2015, having met my now husband in 2014, and we had to move all around the country. We were moving around England. We lived 4.5 hours drive apart for a couple of years because of our various jobs. And eventually, after 7 years of being together, we were finally settled, able to buy a house, and able to get married. So that's a long time to be moved around everywhere. You're sort of your early 30s then, and you still haven't settled down. You still haven't been able to start thinking about children, etc., etc. So it is a long slog, but at least I haven't got to wait all the way to being a consultant.
That is true. But I guess it kind of felt like somewhat living out of a suitcase for those years, constantly moving.
Yeah, I think we worked out that I had lived in 10 houses in 11 years. Because of having to move around so much. And so it gets quite draining packing up and moving again and again and again. It really does take it out of you. So to be in our own house now is just the most amazing luxury. And having a dishwasher, that's surprisingly good as well.
Who knew a dishwasher would be so exciting?
Such a luxury.
Okay, so from your perspective, what are the most important factors to consider before committing to any specialty?
I think one of the things I try and say to people is to consider what the job as a consultant is like. So I think a lot of people can get exposure relatively easily through placements of the junior doctor life as that specialty. But that is something you'll be doing for 5, maybe 10 years of your career, and you'll spend 30 plus years as a consultant. So to really try and think about, does that consultant workload suit me? If you're picking a specialty because you really like the time on the wards, but actually consultants don't spend much time on the wards, they're mostly in clinic or in theatres or doing practical procedures, then perhaps that shouldn't be the specialty you pursue. And think about whether something like going part-time is something that's important to you. But yeah, have a look at being a consultant. Sort of, you can get through being a junior doctor. It takes time, but you can get through it. Most of your career will be as a consultant.
I feel like you just hit the nail on the head, and I'm mind blown because I never actually considered looking from the perspective of a consultant, being on wards and being around the junior doctors most of the time, I guess because we spend most of our time with them. That's who we look up to in terms of their lifestyle and their hours. But when you put it like that, I think I need to change the way that I see my placements now.
Oh dear.
Oh dear. I've been doing it all wrong.
Well,
Okay.
you look at geriatrics specifically, and the time on the wards is often on rehab wards, and you're there day in, day out. Consultants are only there for a couple of mornings a week. They're doing lots of subspecialty clinics and lots of much more detailed insights into small parts of geriatrics. So it's very different.
Okay, so we've gone far and wide, talked a lot about geriatrics, and now I want to move on to just giving general advice to medical students, junior doctors, anyone that's listening that may be a healthcare professional or soon to be. What would you say to anyone who's feeling overwhelmed when it comes to thinking about choosing their career path?
I think don't panic. I think that there will be a specialty out there for you. One of the things I've often said about medicine is choosing to do medicine in secondary school is like not making a choice. There are so many different specialties out there. My dad was a radiologist, and his career meant very little time directly speaking to people. He did interventional radiology, so did have some patient interaction, but compared to, for example, geriatrics, where you end up talking to the entire family in many cases, it's a very different skill set. He was a bit like surgeons would do, much more practically orientated, doing procedures, etc. So don't worry if you don't know your key specialty straight away. You will find it, and there will be one for you. If you don't like patients altogether, there's plenty of specialties that are sort of orientated around that, and that's absolutely fine. So I think just don't panic.
That's reassuring. I know that I've spoken to some of my friends and other colleagues, and the thing we find difficult is we try to engage in societies to set ourselves apart from what they may look for in our portfolios later on. But what if the societies that we were part of, like TNO, or if we were part of Cardiology Society, isn't actually what we want to pursue anymore?
I think you'll find that even if you think, for example, I wanted to be a GP or an A&E, and I pursued various projects, and then I looked back, and the projects I'd been interested in within that specialty actually did link to the specialty of geriatrics. So I'd gone into GP, and I'd done vitamin D deficiency. I'd gone into A&E, and I'd done doing an AMT confusion screen at the front door in A&E. I'd done a placement on general medicine and looked into falls. So I think you'd be surprised how much overlap there is. And if you're toying between two specialties, you probably can find projects, etc., that will cover both specialties. And then if you don't end up doing either of them, it's absolutely fine. It's still a project under your belt.
So what I'm gathering is there's always a skill or an experience to extract from each placement that can go on and actually relate to what you do in the end.
Definitely. You think you want to do geriatrics, and you get interested in, for example, eye conditions with geriatrics, and you might realise further on actually you want to do ophthalmology, but that project was still very relevant. So don't worry.
Perfect. Okay. Thinking back, what would you have done differently, if anything? And what would you have done the same in your journey to becoming a geriatrician?
Um, I'm not sure what I would have done differently necessarily, because I think I've learned from all of the different steps that I've taken, and really enjoyed that. And some things are out of your control. For example, if you have a placement where you are treated beneath your capabilities because of staffing issues, well, there isn't much you can do about that. So it might not be the best use of your year, but it's also all you can do. In terms of what I would definitely do, that would be taking years out. I think being once you qualify, you feel like you're on a production line, and that you've got to sit on this production line and keep going, and go from year to year to year to year, and you will get burnt out. You know, this is a tough career that is really, really tiring. And so I would really encourage people to take a year out after their F2 year, whether that's be to be a teaching fellow, which I think is a fantastic opportunity, or to locum, that's absolutely fine. But just to reset their work-life balance, it's so important to remember to be you, not just doctor you. You need to have a work-life balance, and you need to have some hobbies outside of your career. But yeah, really think about years out, and don't panic if you don't do one F3. You can do one after an SHO, you can do one during your reg training, but do have years out.
Perfect. So don't get tunnel vision about medicine. Just explore your other likes and your other hobbies, as you said, because there's more to you than just being a doctor.
Yeah. And if you are, for example, somebody who is thinking that they want to get all the way to being a consultant before they have children, also that can be very draining. So think carefully if you really want to do that. Actually, there's no reason why you can't have a baby during your training and then go part-time. That's absolutely fine too. Don't go pushing, qualify as a consultant age 33, 34, and then start thinking about children. You can do it earlier, it's fine.
Okay, so that's another element that we haven't really touched on, which is being specifically a female in healthcare and feeling like you have a certain time frame to reach that consultant grade. So can you tell us a bit more about your experience being a female in healthcare?
I think I haven't had necessarily any sort of detrimental attitude towards me being a female. I think there are certain specialties where women can feel a little bit more of an outsider and treated a bit more vulnerably. Geriatrics is not one of them. It's a very welcoming specialty. It's very welcoming of being part-time, etc. I haven't actually told you this, but I'm currently pregnant.
Congratulations.
Thank you. And so I've just told all of my colleagues, all of the consultants, and the resounding response was, congratulations, that's fantastic. How can we support you with your maternity leave? How can we support you? Do you want to be part-time? Will you come back? Of course, we'll help you with that. You know, it's a very welcoming specialty for that. I think the one thing that women do probably get more than men is with sort of biases in terms of what your role is. So, for example, I very regularly will go up to one of my patients, introduce myself as Dr. Megan Stross. I'm the doctor looking after you today. And very quickly, oh, nurse, would you mind doing this for me? So that's probably the main thing that I've noticed that doesn't happen to men. Men are automatically doctors, women are automatically nurses. But other than that, being a woman has not impacted my career at all, and I felt very lucky.
Do you think that there are some specialties that females should consider a bit more deeply before pursuing? Because we talked about how geriatrics is very friendly and very supportive, and I'm sure all of the other specialties also are, but the time that it takes for certain training pathways and the hours that are expected, do you think we should take extra consideration?
I think you should take extra consideration if you as an individual want to. Some women, I think we're in danger of putting all women under the same brush. I have some friends who are doctors who don't want children, and that's absolutely fine. And so trying to say to them, oh yes, you should go for a quicker specialty so that you can then think about having children whilst you're fertile, is completely stupid. So I don't want to start trying to dictate to women what they want to do. Some might want to have children and never come back into medicine, and that's absolutely okay. One of my consultants that I work with, and a few registrars, they're the sole income earner. So they either work full-time or part-time, and it's their husband that stays at home with the children. And so there's so many different personalities out there. Perhaps as a doctor, as a woman, you might think about some of the prejudice barriers that there might be there with certain specialties, where you can feel a little bit like it's a very lad specialty, and do you need to try and buy into this lad culture? But if it's a specialty you enjoy and it's a specialty you want to do, you can carve your way as a consultant, and you should go for it. Don't let people hold you back.
I love that. Don't let people hold you back. And finally, a closing question, and I think it's one that our listeners would really like to hear your response to. What is the best piece of advice you've been given that has shaped you as a clinician?
I think the best piece of advice I have actually touched on, I think through the podcast, actually comes from my husband, who isn't a medical doctor. He's done a PhD, but nothing to do with medicine, and that is to remember to get a balance. You can't be a doctor working in healthcare if you are burnt out, if you've got no balance out there. You need to have hobbies, and it is exhausting if you're moving house every single year in a new city, trying to find a hobby and trying to find a new club. But do it. It is so important that you have time to be you, because that will come across in how much you enjoy your job and how much you're able to give into the job as well. So yeah, look after yourself.
That's quite similar to something I read, I think, on LinkedIn, and it asked, how are you going to take care of others if you don't take care of yourself?
Definitely. Absolutely. And actually get a bit of a branch off from that is that I think many medical students and doctors have a tendency to be a little bit more arrogant, I guess, and more keen to think that they are able to push through and they are able to keep going. But we live in a world where things are tough at the moment, and if you are struggling, please do ask for help. Don't think, oh, I'm struggling, but I'm not struggling enough to get help. If you need help, please ask for it. There are lots of well-being societies around there. I've been involved in quite a few over the years, and your hospital will have support for you, and do ask for it. And if you stop needing it, fine, that's absolutely fine, but do please ask for help if you need it.
Very strong point to finish on. So please, anyone who's listening, if you need help, whether you're a medical student, junior doctor, speak up, let somebody know, because there is many people out there who want to help, but they need to know that you need help first before they can actually act and help you.
Definitely.
Thank you so much, Dr. Stross, for speaking to me today. I hope listeners enjoyed, and please tune in next time for another episode of A Doctor's Insight.